It's always a pleasure to come and really, contribute this morning for the Leukemia Foundation, as they do such great work for really, my patients and also, our colleagues in terms of supporting research. So it's a pleasure to be here again. Now, I suspect, like most sessions, most of the audience, there's probably going to be a bit of a range in terms of knowledge about myeloma. I know some might be very intimately, involved in sort of the condition itself, and obviously some might be family members and whatnot. So hopefully I'll be able to pitch this at a level that's all going to be, helpful to everybody, okay? And just to give you an outline of what I'm going to try to go through in this session is, I'm going to go a bit hardcore today. I'm going to talk about some of the basic principles of blood production and the immune system, because it's really quite, I guess, relevant for multiple myeloma as a disease, which hopefully by the end of the session you'll come to get some sort of understanding. And obviously we'll talk, a little bit more in detail about what is myeloma, and I guess to then discuss some of the current treatments. And we won't be getting to too much nitty-gritty detail per se, but of course, come question time, more than happy to field any questions about specific treatments. And always, to me, I think one of the most exciting things to talk about is always seeing how much things have changed. Just to give some indication, the last time I gave this talk, probably was 2 years ago, already the drugs I was mentioning have been available now in some countries already. So hopefully we'll be able to have a chat about that. Here we go. We're going to go to Haematology 101. I guess blood disorders, unfortunately, are quite complex, and I think it really does help to try to understand a little bit about how blood works, how's it produced, and what's happening. So, well, first of all, just some words that probably get thrown around for some of the patients in the audience. Now, haemopoiesis is basically the process by which blood is being produced by the bone marrow factory. Now, to give you some idea how hard-working the bone marrow is, now, I actually would give $5 someone could tell me how do you describe 10 to the power 11. I think it's a trillion, but I'm not sure. So anyway, but 1 trillion new cells, I think, are produced daily. We need to maintain, I guess, the number of cells required for daily function, in our blood. Now, we know that what gives rise to these mature cells are what we call stem cells in our bone marrow factory. Now, these stem cells are they're quite amazing cells. I mean, they're able to not only differentiate or mature, it's able to give rise to, I guess, different types of cells, which are then able to then keep producing and replacing whatever it needs. And I'll show what I mean by that, hopefully, in the following slides. But I know it's a bit of a busy diagram, because often patients ask me, when you say bone marrow factory, is there, what do you mean by that? There's actually no factory. There's no machines there. But we have basically in our bone marrow, basically lining all the surface of our bone inside our skeleton is where the stem cells live. Basically, stem cells live here. So they basically stick on to the surface of the bone surface, and that's where they do their magic. They multiply and they release all the cells into sort of the bone marrow fluid. And then they kind of escape into, I guess, the circulation. Sorry, I don't have a pointer. Why do sort of central sinuses or arteries, okay? So they're kind of released out into the circulation. And then, that's what's happening in the bone marrow. So now I mentioned before, I noticed once again a bit of a busy diagram. And really what I'm trying to illustrate here, which I wish I had a pointer, but I might have to do this, is that we have the stem cells up top, which are able to give rise to different types of, I guess, parent cells, who will then be able to produce more mature forms of cells, which ultimately get released into the blood. So for the red cells, there is a red cell grandfather cell that's able to multiple maturation steps eventually develop a mature red cell that gets released into the blood. Okay, and the same thing happens for the other components of blood. So on this hand is the platelets, or the cells that really help with stop bleeding, sorry. And the myeloid and the lymphoid stem cells are the ones that give rise to all the white cells, which comprise really our immune system, okay? I just want to point out this one particular cell. Oh, thank you. Awesome. obviously, really one of the main characters of today is going to be this plasma cell, which obviously is intimately associated with multiple myeloma. And I just want to point out here that it actually belongs to this family of lymph cells. And really, it's, I guess, a cousin of the B lymphocyte. And we'll go into a little bit detail about that a bit later. So, what is our immune system? Well, it's basically there to protect us really from against infections. And I guess, like any good defense system, it's number one, it's got to be able to recognize what's foreign or what's attacking us. Okay, so that's something that's very important. And once it's able to recognize what's foreign, there's another component of the immune system that's then able to kill what's been tagged, I guess, as being foreign. Okay, now, and it's very interesting that within our body we actually got two, I guess, general groups or general defense mechanisms, which is able to protect us. We talk about this first line of defense, or what's known as the innate immune system, and there's also, I guess, a more effective and stronger response that we define as the adaptive immune system. Now, I'm going to try very hard to now explain what is a very complex concept, the next few, I guess, slides, hopefully. So what the first line, this innate system is basically, is able to immediately immediately recognize that something's not foreign, what's the word? That something's immediately foreign to the body. And that response is almost instantaneous. But unfortunately, that response is not very strong at all. But it's the first line of defense. It's there to wait until the reinforcements come. And the reinforcements requires our immune cells to be able to recognize and process that, yes, this virus is foreign. We're going to produce markers that are going to tag that virus, so-called antibodies. And then you have this overwhelming immune response that will be very effectively then kill that virus or whatever foreign organism is. And really, I guess this table, I know once again, is a bit complex, but really just summarizes that innate system is immediate response. Now, it's not what we call antigen specific, in that it doesn't know that it's trying to kill virus A or virus B. All it knows is that that thing is foreign. It's able to do that because it could recognize that with foreign, I guess, viruses or bacteria, that there are certain proteins on those bacteria that doesn't exist in man. So therefore, it automatically knows that that's foreign. Now, the problem with that sort of first-line response is, I guess, it's a bit of a, for want of a better word, a dumb response, in that it won't be able to remember or know, in fact, what it's attacking. All it knows is, that thing does not have something that looks like us, we're going to kill it. So it's a bit of a sort of a straightforward, I guess, dumb response, for want of a better word. And these are some of the cells, I guess, and it's probably too much detail, but these are some of the cells that are able to have that ability of immediately recognizing that virus A is not part of the human system, and they're going to just attack it, and they're not going to forget about it. When you have another viral infection, even if it's exactly the same one, it's not going to remember, hey, I saw that thing 2 weeks ago. It will just still attack it exactly the same way. Now, this is where the adaptive immune system is a lot smarter, okay? I guess there is a bit of a lag time between getting an infection and for this adaptive immune system to fire up, because it takes a little bit more time to process. Now, the thing about this response, though, it actually knows what it's attacking. And the best way, I guess, I could explain what this adaptive immune system is like, it's just like the customs area at our airport, okay? As a pain in the bum as they are. But as you come through to customs and get processed, what do they do? I mean, they process your passport, they look at your face, and they look for the database, and they go, right, are you really Mr. Smith? And have we met you before? Have you come to the country before? Are you a threat? And that's exactly what this immune system is able to do. It's able to recognize that, hold on, you are virus A, influenza. I met you a few weeks ago. We didn't like you very much. In fact, we produced an immune response against you. So it's able to realize that. And because it's able to realize that, it's able to harness a different arm of our immune system, the lymphocytes, to then be able to reproduce the same immune response they had the first time round. And it does that by producing these so-called antibodies or markers that will be able to recognize that's influenza A again. Let's produce these antibodies that tag it and then recruit the rest of the immune system to then kill that virus. And unlike this innate system, that response is 10, 20, 30 times more potent. Okay? And it's a specific targeted response because it knows that this is a virus, virus A, and because there's tags, like, the antibody is able to tag all the virus in the body, that response is far more effective than this, I guess, it's like the rather big, tall bouncer at your nightclub who probably doesn't differentiate between one patron or the other, except if you don't have the right shoes, he will kick you out, okay? Or if you're too drunk, he'll kick you out. So I'm not going to say they're not intelligent, but just that they don't discriminate as much. So does that kind of, I hope, sort of give you an idea of what those two different types of things are? And I guess what I want to point out, I know I said ignore the cells there, but note that in our adaptive immune system, B lymphocytes, plasma cells are involved in that effective second-line adaptive response, okay? I've literally summarized, I think, someone's thesis just then. It's a complex concept, which I hope I'm able to impart. Now I mentioned, I guess, that with the adaptive immune system, A, it's got to recognize something's bad. 2, it produces markers, what I call antibodies, directed against that thing. Now we know that a specific cell in the blood, the plasma cells, are the ones that start producing the antibodies. So this is how we know. This is what happens with these cells. When the plasma cell, which is derived from the same family as these so-called B lymphocytes, they basically, when they're released from the blood, these B lymphocytes have two fates. They either grow up to be, they grow up to be many different things. But when they encounter something foreign, they then differentiate into two jobs. They're going to decide, okay, I'm going to be a doer. I'm going to try to kill this thing now and start producing antibodies. If it does that, it becomes a plasma cell. But it might be a bit of a thinker and decides, I'm not going to get my hands dirty. I'm going to become a memory cell instead, where I'm going to remember that thing is foreign and lay dormant and wait until it comes again next time. Okay? And that process would happen with, concurrently. So what will happen, whenever these B cells encounter, these naive B cells encounter something foreign, they're either going to go, I'm going to start producing antibodies and do something about it, or they're going to decide to go dormant and go, I'm going to remember that for next time. See you later, boys. You guys do the work. Now, and of course, we're very interested in plasma cells, as I'll talk about later on. Now, we know that in plasma cells that they are normally not found in the peripheral blood, because you imagine you only produce antibodies or become activated when you meet something foreign. So normally when you're well, you shouldn't have any circulating around. But it makes sense that when you have times of stress or infection, kind of makes sense, you can see 1 or 2% circulating around as you try to kill off whatever it is that's invading the body at that time, okay? But generally when you're well, we shouldn't have any in our blood. But when you have a cold or whatever, it will fun a little bit. And why did I put this in here? I think to punctuate all that words with pretty pictures, and just to give you an idea of what the plasma cells look like. I'm sure some of you in the audience might have had bone marrow biopsies, and really this is what we're looking for in the bone marrow, because these plasma cells live in the bone marrow. Now we know that a normal number should be really less than 10%, and we have a very actual characteristic look about them. They're nice round cells and have this sort of clearing next to the nucleus, which is really one of the characteristics, and that's what helps us, I guess, easily recognize them as being plasma cells. So they're pretty impressive, I guess, cells, these things. I mean, first of all, we know that they have a really quite an indeterminate lifespan, which is a bit different from normal white cells, where they probably hang around maybe 7-10 days. These guys are a bit more resilient. They can hang around for days to months once they, have come into being, where they've encountered something foreign, they realize I've got a job to do, I need to make some antibodies. They hang around. kind of makes sense that, you know, they're trying to protect, to mop up anything that, you know, that's invading the system. And I guess what they're very good at is secreting these sort of high level what we call antibodies. And they're really quite efficient in doing that. I could make hundreds to thousands per second per cell of these antibodies that's able to tag on to these foreign bugs or germs or whatever, which then, you know, as I said, they're markers. They basically then tell the rest of the immune system to destroy that foreign thing. And they're very, very specific, you know, because literally one plasma cell would know only to target one specific bug, and that's it. Okay, so they're very effective. It's like a sniper bullet as opposed to, you know, this sort of arterial bombing, which the States do a lot. You know, they actually only target that one cell, and that one cell only. And that antibody recognizes literally only a small part of that one viral particle. So it's very targeted, very specific. Now, just deviating slightly, just because this has some relevance to some of the testing that I'm going to talk about a bit later. You probably hear the words immunoglobulin for some of the patients in the audience, and antibody. They're actually exactly the same thing, and we don't know why we have two different words to confuse people, but they're really describing the same thing. They're essentially just proteins, okay, these so-called markers that look like this Y-shaped thing. They're made up of really of two main components, and this is important for a bit later on when we talk about testing. They're, you know, what we call a pair of heavy chains, this bit here, and then a pair of light chains. Now, I guess the reason for this strange Y-shaped business is that it is these little tips of the so-called Ys that actually what attaches to foreign bugs or viruses. And you know, we now know that once these things attach to a virus or germ, it is this bit here which our immune cells are able to then bind to and destroy whatever is attached to that. So the rest of our immune system, they actually don't know they're killing virus A. All they know is that, look, the plasma cell boys have done our job. They have tagged something as being foreign, and all we need to do is whatever, you know, we stick to this, and whatever's the end of that, we're going to destroy, okay? And we do so very efficiently. And yeah, so just to really, the main message from that is that, you know, they're comprised of these heavy and light chains, which will make sense hopefully a little bit later. Now we know that antibodies or immunoglobulins, they come in different classes the way to think about these classes is that they just look slightly different. So there's 5 different types that are found in humans, which would kind of make sense a bit later when we talk about myeloma. Okay. Now, this might be a hangover from my previous talks where I think I do digress and talk about some of the other plasma cell disorders, which I don't think we're going to have time for today. But I just want to point out, I guess, that besides myeloma and its related more benign condition, this monoclonal gammopathy of unknown significance, we know that there are other, far more uncommon problems with plasma cells that could cause disease as well, which, if we had time, I'm happy to answer questions about them later on if anyone's interested, but we might, in interest of time, try to get through the bulk of this. Now, I'm going to make things a little bit more interesting and talk about history, which I'd sucked at in high school. But it's actually really fascinating, medical history. You would not believe that, so multiple myeloma, we know the malignancy of these plasma cells. Since 1800s, it's probably when it was first, really recognized by, very clever physicians then. So Otto Haller was the initial one to describe this condition where patients had, were anemic, fatigued, with multiple fractures and bone pain and whatnot, and went to renal and, stopped producing urine. So, more than 200 years, well, almost 200 years ago, they recognized that, that people were getting that condition. So obviously been around for a long, long time. But it was probably, this English surgeon, ironic, who first really brought it to attention and really, really through more, more scientific methods, had, labeled it as, this is truly quite a distinct condition with very interesting manifestations. And some of you might be interested, Bence-Jones protein. Has everyone heard of that Bence-Jones protein? Yeah. And it's basically described, one of the, I think we'll talk about it a bit later, but it's to describe the light chains that's produced abnormally by the myeloma cells being found in the urine. And it's actually named after this chap, Dr. Henry Benz-Jones from St. George Hospital in England. And yeah, so 1848 when he first discovered that. So there you go. Been around for a long time. Now just a little bit of snapshot in terms of how common is myeloma. So I mean, this malignancy, if you have a look at it, about in Oz, and I think this is data from 2009, I think. So it will affect 5 per 100,000 patients in Oz per year. Okay, that's the estimated incidence. As you could see there, it is very interesting that there is, strangely enough, an ethnic, I guess, distribution where it seems to be, patients from Asian backgrounds have a low incidence, and the highest incidence the highest incidence occurs in really African Black Americans. Really twice the incidence, and certainly you see that in the States where there's just it's very clear there's a much higher incidence. Now we know that this malignancy of plasma cells, that the median age of diagnosis is actually fairly late. It is something that we know affect older adults, and I guess for us as hematologists, what we're very reassured with is that really we've actually made huge gains in terms of how we treat this disease. In the bad old days, I like to think, only 30% of patients were still alive in 5 years' time, and you could see that within sort of two decades we almost doubled that rate, and that was even before the wide availability of the treatments we have now. And it'll be very interesting to see, certainly for the next few decades, I suspect that's going to be a lot higher. Now, I guess this is hopefully not going to be a shocking statement to people in the audience, but we know myeloma, that it is sensitive to treatment, but for now, we still have to say that it's generally not a curable condition. There are a very small caveat for that in terms of stem cell transplants, which I think I'll talk about right at the end. But I guess we know that with this disease, with certainly the treatments we have now, it is sensitive to treatment, but we know if we wait long enough, it will eventually come back, where we didn't have to retreat again. Okay. Now, as probably some of you in the audience will know, I mean, so how does this malignancy of these plasma cells, that they're there, they're meant to make antibodies, what do they do? What happens when you have this malignancy? Now, because it's affecting cells that reside in the bone marrow, normally, we know that it could disrupt the normal bone marrow. And how it does that basically is just sheer physics. By growing and growing and growing, as all cancers do. Remember how I showed you that previous diagram of the bone marrow, where literally the cells are lining up, really against the bone. It just fills up, literally, that bone marrow space, okay, just from sheer mass effect. And when that occurs, it leaves no room for the normal stem cells to be able to grow and gain enrichment from all the proteins. It literally edges them out, okay? And that's when we know when you kill those cells, what happens? Then there's room to grow and your counts improve, okay? Now, this has now become no surprise to us all now, given hopefully that short immunology talk, that it will reduce your immune function. And why? Well, now we know, because these plasma cells are meant to be producing these antibodies that are protective and helpful. But when you have a huge number of plasma cells that are basically malignant, instead of able to produce, I guess, new antibodies against foreign things, they're all being kind of edged out almost. They're just all producing this single useless, really, protein that's not really going to help you out at all in recognizing anything that's invading the system. And so it really, reduces, I guess, the production of normal antibodies because it just doesn't leave any room. Now, something very specific about these plasma cells is that they really like really homing into bone. And it's interesting that we're still not entirely sure the reasons for that, but it just loves to really go and stick to bone and activates increase what we call resorption of the bone. And that's what gives rise to the lytic lesions, as some of you might know, where it literally it punches and eats away little holes all throughout our bony skeleton. And this, I think, we kind of make sense now that with myeloma, we now associate this production of this what we call a monoclonal protein or immunoglobulin in the blood. So this is where it gets confusing, isn't it? We talk about all these funny proteins. We talk about immunoglobulin, paraprotein, monoclonal protein. They're all the same thing. Okay. So I guess the definition of paraprotein, it's really an immunoglobulin. That's what we call monoclonal. Because what should normally happen is if you've been invaded by an organism, many different types, the plasma cells produce different types of antibodies depending on what's encountered. So in your blood, I guess you should have lots of different plasma cells able to produce different types of antibody. In this condition of myeloma, they're all producing the single one because they all come from the single cancerous cell. They're exact clones of each other. Okay? So all you will produce is a single identical, or what we call monoclonal, protein or antibody. Okay? So that's what all these, I guess, jargon really means. In a way that's very useful now that we understand this, because we now know that, well, if we measure the amount of that abnormal protein, that should then reflect the amount then of the abnormal plasma cells. And give you some idea, I guess, of how active this malignancy is. And I'm sure most of you will be familiar that really this is the main way that we monitor myeloma. But the reason why we call myeloma multiple is the fact that the multiple skin, the bony lesions which occur with this disease, and literally it's really anywhere that could occur. Just to highlight what lytic lesions look like for those who might not have seen their own X-rays recently, you basically see little hollowed out, I guess darker holes in the bone, which shows that it's basically thinned. And it can occur also in the in your spine, which is what these little black bits are. And these are just more pretty or ugly photos of plasma cells, depending where you're coming from. So now, in terms of how patients actually present, and I'm certainly interested what some of your experiences are. But believe it or not, the most common symptom is none, asymptomatic. More than 50% of patients. They get picked up because a blood test shows they've got a high protein, and they get sent to a hematologist to investigate why is the protein high. But I guess in some patients, they will unfortunately present due to the fact there is organ damage. And I guess the most common one is going to be the bone damage, causing pain, because that's what normally triggers us to go see a doctor when you're getting pain, or in some worst case scenarios, actual fractures. Fatigue is something that's also quite common, but that's something obviously very subjective. I wake up most mornings fatigued before coffee, so that's really tricky. So it's hard to tell whether it's due to anemia or whatnot. So there's no surprise that I actually published an article looking at GPs trying to diagnose myeloma, and they came, the great majority have seen a medical practitioner in the preceding 3 months. With very non-specific symptoms. And especially in the UK, where there's very strict rules on what tests you could order, most GPs going, you're 60, you've got diabetes, high blood pressure, you're tired. C'est la vie, sort of thing, and then don't do any other investigations. So it's not surprising that, it just sort of grumbles along until, unfortunately, something really serious could bring you to medical attention. So this one we don't see as common, but you can get obviously recurrent infections because of relative immune suppression, the lack of immunoglobulins. It could be anything, pneumonia, urinary tract infections, or I guess reactivation of your chickenpox causing these shingles, which I hope none of you had the displeasure of experiencing. The kidney damage and the high calcium, that's a little bit hard, because that basically will present with basically you feeling tired and fatigued and nauseous, which really quite, if you think about it, non-specific and quite subtle. So is the high calcium, and just makes you feel tired and maybe a bit nauseous or constipated. But if you imagine, I can imagine how difficult it is for GPs to be fronted with those very non-specific symptoms. Without a blood test, you just never would know. Now, so I think we talked about sort of subclasses before. So although we said there were 5 different immunoglobulin classes that technically, any of them could become cancerous and myeloma. But we know for a fact that the great majority, 80%, are going to be IgG and IgA myeloma. Okay, so that the myeloma cells are producing that particular class of immunoglobulin. very rare is the M and also the D and E types of myeloma. In fact, I've never seen, oh no, I've seen IgE before. Yeah, so really, really quite rare. What's interesting is that now what basically is happening, to pick up a paraprotein, you have to have a myeloma cell that, although obviously not normal, but normal enough is able to produce and assemble an intact Y-shaped protein, right? And remember how that immunoglobulin is two components, a heavy and a light chain. It's got to assemble it and then release it into the blood. In 20% of patients, the myeloma cells, I guess from one of it, they're so abnormal, they can't even produce a normal intact protein. Instead, they sort of break apart or have any part of that abnormal protein being secreted from the myeloma cells. And we could only find the light chain component of the proteins trying to produce. Okay, so we will not find a paraprotein, as in the intact protein. You only would find light chains in the blood. This is very tricky because you've got to specifically order a light chain test to find that, or urinary Bence-Jones protein. Okay, so it makes it even harder for the poor GPs, where someone comes in and they might be cluey and think, gosh, you've got bone pain, you've got anemia, you've got this, but you've got no protein in your blood. You can't have myeloma, don't worry about it, we'll just see you in 4 weeks. When 1 in 5 patients with myeloma, you're never going to find that protein. You've got to look in the urine or do this specific serum-free light chain test. Okay. And what's even more difficult, in 1 to 2% of patients, you can't find anything at all. There is no light chains, no paraprotein. They'll have all the lytic lesions, they'll have anemia, they have high calcium. And you think, what the heck is going on? You do a bone marrow filled with myeloma. Really difficult, because to monitor these patients, there's only one way: bone marrow biopsies. Okay, and look, we still know for a fact that that's still the gold standard technically, but why would you, when 98% of patients have a protein, have a protein to measure, but in those patients you don't have a choice. You really got to just do bone marrow biopsies. This slide I was referring to in terms of trying to help highlight this concept of that you could have high total protein levels, and the reason why that could indicate is myeloma. So this is the testing that we would that most patients get done every month, you poor guys, where we look at this serum electrophoresis. Now there's a fancy word to describe a process where we literally take your blood and then we run a current through this. We put onto this sort of gel, run a current through it. And just because the current would then push the proteins down that gel, it kind of would separate into, depending on how heavy they are. Now when we do that, we know, I guess, how heavy most proteins are. And we know that, yes, albumin would be would be one of the lightest ones, and we have the most of that. So when we do the total protein assay, it measures all of this. Okay, so that's what that total protein means. It's actually measured all of these different types of proteins. When you do a serum electrophoresis, if you guys will probably have read in your results that they talk about an alpha globulin, a beta globulin, or gamma globulin bands. And what they're talking about is they separate the total protein into these different little areas. And we know most antibodies or immunoglobulins sit in the gamma globulin band. Okay? So in myeloma, the gamma globulins tend to be high. Now, normally we should see just that amount of quantity only. But in myeloma, you see this, what we call this monoclonal spike in protein, which just means there's a lot of a protein of a certain weight and appearance in your blood. And we see that, we know, bing, this person likely has myeloma. And we have very fancy ways to then actually identify what class of immunoglobulin it is. Okay? So we actually always need to order 2 different tests. We do a electrophoresis, which gives you this and gives you a quantity, but it doesn't actually tell you what it is. It just says that there is 40 grams of protein in the gamma globulin region that should be immunoglobulin. We don't know what it is though. So we do what's called an immunofixation, which is what this is, where you're basically able to tag and tell us, oh, it's an IgG or IgA protein there. And the two together, we figure it out. 40 grams of an IgA protein, clearly abnormal because it's far higher than what it should be. Okay. So, yep, that's what a serum electrophoresis is, and what you get every month. Well, you do anyway, Peter, sorry. And that's how we monitor for myeloma, okay? Now, I think this is just a slide to highlight this whole concept of the free light chains. As I mentioned, if this is your Dickey myeloma cell that's spewing out all these antibodies, which should look like this, a heavy and a light chain, if it's normal enough, you'll produce a normal intact paraprotein that you could detect, but sometimes it doesn't. It only has a fragment of only the light chains. Okay, and that's what we could measure now in the blood. Oh, I did keep it in. Oh, okay, there we go. And look, this is something that's really relatively new. In the past, we could only use the same technology that I mentioned, the serum electrophoresis, to look for the Bence-Jones protein. Okay, but we now have a much better assay where we could measure actually the light chains in the blood. And to give you some idea how sensitive it is able to pick a very small amount of light chains in your blood, far better than the other two conventional mechanisms. So this is, in your situation, Marty, when you mentioned how could you have a serum-free light chain in the blood but not in the urine, because we use this method to pick up the urinary Bence-Jones protein. So if it's less than 0.15 grams, you won't pick it up. But the serum-free light chain will, because it could pick up as low as less than 0.005. That makes sense? So it's just more sensitive.
So I'm getting a bit confused with the serum light chains. Are they just parts of that M protein that's
yes,
broken off?
Absolutely, exactly. So exactly that. Because we know, probably a bit, don't want to confuse you guys, but when the paraprotein is being assembled inside the plasma cell, if it's intact and normal enough, you'll just be spat out as a whole, and you'll be fine. If it's so unstable, though, before it gets spat out, what would happen is the heavy chain kind of falls off. Now, the heavy chain we can't normally find in the blood because it actually gets recycled inside the cell. So it kind of just falls off, and then it just sort of oozes out. So this is a light chain component only, okay? And that's why you won't find an intact protein because it's too small. So when we run the gel, we can't find it because it's too small. Does that make sense? Because if you imagine it's a small portion of the total complex. Okay. So now there was a question about, differentiating against the related disorders. I know we've all been really, I guess, when we think about multiple myeloma, we all, in our mind, thinking about this. But we actually know there's a completely, I guess, more indolent or slow progressing form of myeloma that we define as smoldering myeloma. So we might concentrate on the symptomatic myeloma for a second there. So this is the current International Myeloma Working Group definition of myeloma. You have to have two of the three of these criteria, where we need to see that you have a monoclonal protein in the urine, light chain myeloma, or in the blood, normal, I guess, myeloma. You have to be able to prove that there is an abnormal population, clonal, of plasma cells in the bone marrow, or I guess in some patients, you could just have it in the bone and not in the bone marrow. And that's a separate, slightly different manifestation, okay? And then, I'm sorry for the damn abbreviations, but you've got to have what's called related, organ or tissue impairment. And the easy way to remember this, I tell all my registrars, is remember CRAB, terrible word, but that's what we look for. CRAB, C standing for the high calcium, R for the renal failure, A for anemia, and B for the bone lesions, okay? So if we have two out of three of these features, you have myeloma. Now note that we don't define a quantity that you need. All we need to say is that if you find the presence of a monoclonal or abnormal protein or in the blood or urine, you have myeloma. And I have a patient exactly in this situation right now. The bone marrow has got less than 10%, which used to be what I mentioned normal should be less than 10. Well, it's got less than 10% plasma cells in the bone marrow for repeated biopsies. It's got 40 grams of paraprotein. It's got end organ damage everywhere. And in the past, we would have said, oh, doesn't fulfill criteria, but we now know it doesn't really matter what the, as long as you've got 2 of the 3, you've got myeloma. Now, on the other hand, with smoldering myeloma, really the main difference between these 2 is the fact that there is no evidence of end organ damage. Okay, you may have everything else, but there's no evidence of end organ damage. Patients could remain in smoldering myeloma phase for years, okay, decade, without any progression or sign of disease affecting organs. So we generally do not treat anyone in smoldering myeloma. And they've actually done studies, I guess, where in the past they treated people straight away to see whether it affects the ultimate outcome, and there's no change. They live just as long. The disease is just as responsive when it became, if it did transform to active myeloma, but they all had poorer quality of life. Why? Because they were well. There are no symptoms. You gave them chemo, and some people know what that feels like. You don't feel great. When in the long run, it didn't change anything at all, except maybe made us feel better that we're treating something. But we now know that we don't treat that. Some of you might have Googled, read about use of high-risk smoldering myeloma being treated with, say, curcumin or something. That is very controversial at the moment in terms of whether we treat what we call high-risk patients of smoldering myeloma, because there's always a risk that you'll progress into active. But for now, unless you're in a clinical trial, we will not treat smoldering myeloma. Okay. Now, down the ladder even more to an even more benign condition is this MGUS, monoclonal gammopathy of unknown significance. It's a very fancy name that we really was a condition that really we made up. Reason because with our testing, we were able to pick up, with the more wide availability of serum electrophoresis, that patients have these paraproteins in the blood that's less than 30 grams, so it's not a lot. The bone marrow is completely normal, less than 10%. There is no end organ damage, and no evidence of other, I guess, B cell, what we call lymphoproliferative disorders or lymphomas. Now, this is to answer that question: Can myeloma evolve from other conditions? Yes, it could evolve from monoclonal gammopathy of unknown significance. But generally, most of these patients are completely benign. They will go for years and years and decades and remain exactly the same, and more likely die with MGUS than die from MGUS. So it's more like a label that you sort of wear. But I guess there is a very small chance that it can evolve to myeloma, and I generally would monitor patients at least once a year, if not more often, to make sure it hasn't evolved. Okay. But a completely benign condition as you think of it. This is just a slide just to show that what is distribution. We know that really 10 to 20% of patients who present with what we think as myeloma has got this smoldering phase, and that could, as I said, remain indolent for years. Now, I guess we know that if you wait long enough, at 5 years, half the patients would have unfortunately have done the deed, crossed that line, and developed organ damage. And there's this concept that there are patients of high risk groups, and they're the ones that are very high, with very high levels of paraprotein. That, or I guess there's some of the, when we look at the bone marrow, the cells could look quite abnormal, which put them at higher risk. So this is, I think the main big area of research is going on is, well, A, do we need to treat, and if we do need to treat this smoldering myeloma, how do we pick the ones that are going to respond? So a lot of the curcumin trials, a lot of patients come to me, they've read all these things on the web, with all these Americans saying, it's been fantastic, my myeloma's gone, with curcumin. And it's actually based on research really from our very own Sydney hematologists, actually. But the thing with their study, if you look at it very closely, is they can't predict who responds to the treatment for smoldering myeloma. So the high-risk guys, the ones you really want to treat, they don't always respond to it. When the ones are low risk, they respond, but one has to argue, so what? Because why if they have, without treatment, they might have still gone on for many, many years without treatment. What we really want is the guys who are high risk. And I know a lot of my patients ask me, should I be on curcumin, along with my other treatments? And I have to say, there is still no convincing evidence especially if you've got active myeloma. In fact, in active myeloma, there's no role for that in active myeloma. Okay, so only the smouldering and the MGUS that curcumin, some publications about its use. But I just really want to point out how common it is. 3% of the population at the age of 50, and as the age progresses, that rate increases. Okay, so imagine that out of 100, 3 patients at the age of 50 will have MGUS. Over the age of 70, that probably almost, just under 10%. Okay, so it's actually quite common, and the rate of progression we know is actually, is really relatively slow, but I guess if you wait long enough, that risk accumulates. So generally I say that, in 25 years, you've got a 1 in 10 chance of it progressing to something else if you had MGUS. And we know that there's some, risk factors for MGUS that may put you at a higher risk of transformation, but we really wouldn't act on that information, so to speak, because it just freaks me out, freaks the patient out. So I try not to look, and we just roll with it. Now I know we're running out of time, but I just want to briefly, outline some of the treatments that some of you might be very familiar with, and really probably general principles for those who haven't had any treatment. That really the current approach to myeloma is we basically determine whether a patient is what we call an autologous stem cell transplant candidate or not. Autologous in that we're using your own stem cells as part of the process. And that makes a big difference, okay? Because you really it means that we'll have to avoid certain drugs that might poison the bone marrow, so to speak, to make it harder for us to collect stem cells from you. And that's the only reason why we do differentiate between those two arms. Now, I guess most of you, I suspect in the audience, belong probably to this group who've been through the process themselves. And there's always this induction phase where we give you 4 to 6 cycles of chemotherapy. Then we collect your stem cells and then put them back in you after we give you this high-dose melphalan treatment. And then there is this sort of really controversial thing concept that's coming up, this concept of maintenance treatment. That after you have your initial treatment, we know eventually it would come back, but can we do something about it, prevent it from coming back? And I'll talk about it a bit later because it's very controversial, that some of you might have even spoken to your doctors about. Now, I guess the gold standards is one of the fancy drugs that we've had in terms of bortezomib or Velcade and Revlimid or lenalidomide. The gold standard is still the stem cell transplant. We know by far that still gives you the most, longest and deepest remissions. It is being slightly challenged by the new combination treatments that we unfortunately can't access here in Oz due to the government. In Europe, they're very keen on combining everything. So just throwing everything at a kitchen sink at the patient, giving him Velcade and lenalidomide and steroids all together with maybe cyclophosphamide. Quite toxic, but then they're getting results that may be similar to an autologous transplant. 2 schools of thoughts on that. We say you guys are crazy. That's why Europe is broke, because you guys are throwing everything at the kitchen sink. When this is just as effective and far, easier and I hate to say it, but cheaper than doing that. And it also means that what do you do with those patients that you've thrown everything at and they relapse? More expensive treatments. So unfortunately, it's different schools of thought on that. The Europeans have that kitchen sink approach. The rest of the world, I'd like to think we're more sensible, and then we don't do that, and that's why we're not broke. And now in terms of the eligibility, as most of you might have gone through the process. It really depends on the transplant center. I mean, some people are more comfortable with transplanting slightly, I'm not going to say older, but just slightly more mature patients. It all depends on really a number of things. Disease state. Some of them consider risk of disease in patients who are a bit borderline, where we think, should we really put you through transplant? And I guess it also depends on whether you're responding to the treatment or not. Okay, because if you're seeing that with the induction, your disease is not chemosensitive, we've got to think outside the square and might use other methods. And of course, organ function is a big issue because melphalan, the chemo we use, depends on kidney function. So we haven't optimized that. You can't do a transplant. Yeah, no, I'm just going to go, there's only a few more slides left, I think. I'm going to skip, most of the induction therapies because, as I mentioned earlier, we're limited really by what PBS tells us we could use. But I can tell you right now that if you're a transplant candidate, most people use a Velcade-based treatment in the story, okay? If a transplant ineligible, we still likely would use a Velcade-based therapy, but more options become available because I guess we're not so worried about it poisoning your bone marrow and not able to collect cells later on. And these sort of treatments could actually go on for, for many years to be able to control the disease. Okay. Now, just briefly, why do we give induction? Why don't we just go straight to the transplant? Well, really is try to I guess, debulk the tumor as much as we can. Because imagine we're going to collect your stem cells. The last thing we want is contaminating myeloma cells in there. It's got no point putting them back into you. So the induction, we try to clear the house, okay? To clean the bone marrow up as much as we can. And probably no surprise that the deeper a response you get, the better or longer the remissions normally are with transplants. We're going to skip this because most of you probably had these. I was going to talk about the drugs briefly. I'll be super brief. So basically, thalidomide and lenalidomide, we don't really know how they work. We think what they probably are doing is re-stimulating our immune system to teach them those myeloma cells are actually bad. Okay? And the beauty about that approach is that if that's effective, and we've seen this, patients will be on remission for years, sometimes with these sort of therapies. And the issue with these drugs sometimes can be difficult to tolerate. Neuropathy is an issue with thalidomide. They also increase the risk of clots, and I'm so sure some of you who want to have felt this, the constipation, the fuzziness in the head, and the drowsiness. Lenalidomide, we know one of the big issues is suppresses the bone marrow, which is not, could be quite problematic. Could people at risk of infections. I think most of you will be familiar with Velcade or bortezomib. Really, it's a very effective therapy, basically. But once again, peripheral neuropathy, unfortunately, is one of the biggest problems with it, occurring in probably around 10 to 20% of patients of varying degrees. Now, just want to briefly talk about maintenance therapy. And I'm just curious, and please feel free not to raise your hand, but has anyone talked about it with their physicians at all, or on maintenance therapy at all, post-transplant? No, good, actually. The reason why I mention it is because I'm increasingly getting questions about that from some of my patients who've been Googling. Now, I guess some studies have shown that yes, it delays the disease from coming back. Okay, and some older studies show that maybe actually improves survival. But the problem is the drugs we have that we use for maintenance, thalidomide, lenalidomide, or bortezomib, is they're still quite toxic. And our biggest problem, here in Oz is, the government would not let you use them as maintenance as well. That's a separate issue. I must say that even if they were available, we would not recommend maintenance unless there were very, very good reasons, because of the fact that there are significant toxicity of the treatment with still unclear benefits for maintenance therapy. Okay, so I guess just want to put that out there right now, that in case you ever do come across any literature or forums or myeloma forums where overseas, especially in Europe, they do a big on maintenance therapy. As I said, that's why they're broke. Where it's very expensive treatments where we're still not sure there's actually, in the long run, benefits the patient. So we do not use it outside of a clinical trial, maintenance therapy. Now, just want to finish up with really what does the future hold for myeloma? And incredible progress is made in the last decade. And there's been a huge surge into the myeloma research, which is fantastic for us to see, for us treating patients in the front line. One of the drugs that really is around the corner, hopefully, is pomalidomide. Oral tablet, I like to say, is sort of the supercharged steroid version of thalidomide. And it shows really quite good activity, even in patients who are resistant to our current treatments, lenalidomide and bortezomib, which we consider to be really quite potent. We know that in patients who really, if you had a patient in this scenario, there would be minimal treatment options there. 1 in 5 will still have some response in these patients, and 60% of patients are still able to really be alive and with their disease a year down the track, which is far better than what we would expect for patients normally who are resistant to these very potent drugs. And the great thing about it is no neuropathy, which is fantastic. Now, some of you might have heard of this very exciting new drug, calfizimab, which is once again a supercharged version of we think of Velcade. Has shown incredible promising results, usually used in combination with other drugs. Once again, the great thing about it is less toxic and also still very effective even if you had Velcade. So if you failed Velcade, despite being the same class of drug, is still able to show some response. And we're certainly still, I think some centres in Sydney are involved in the trial of carfilzomib, but that's something the one that we're looking at very closely, because we suspect that that's the one that's going to really replace Velcade, for want of a better word. One of the other very exciting new agents is going to be an oral form, basically, of really, well, Velcade or carfilzomib. So unpronounceable, exactinib. So that's my attempt. That one we'll be watching very closely as well, because imagine that, no more injections of Velcade, you just take a tablet. I think that'll be great. We'll skip that, that's just a bit too nerdy. So interesting that, there's also old drugs that we're now showing some response in myeloma that we're using in the relapse setting. And bendamustine is one that's certainly used with some good results recently. And even patients who've gone through everything, this sort of bendamustine, which is an infusion that you give once a week for 2 weeks, every sort of 3 weeks, can show some efficacy as well. And this one you could, unfortunately, none of these drugs are obviously PBS covered, that I've just discovered, covered. Bendamustine you can buy. Expensive, about $15,000. And I've just listed really a whole bunch of really quite promising trials that are currently ongoing recruiting really all over the world, where we're looking at a whole different class of agents called the HDAC inhibitors, which have been shown to be, in early trials, to be quite effective for patients who are resistant to the traditional therapy now. And more is coming. 2 years ago, we haven't even heard of these agents. And they already completed really phase 1 trials now, showing these whole new different classes of agents are showing activity in myeloma. So I think it's a very exciting time, certainly for me as a clinician, that we have all these medications that hopefully will come through in the next few years.